Physiology of Menopause and Hypoestrogenic Change by Nandi Brown, Ann Niedermeyer, and Audrey David. The overview of menopause. Menopause is a normal, non pathologic condition that occurs in all women. We tend to see vasomotor symptoms, cardiovascular changes, and urogenital um, changes as well. Life expectancy is beginning to increase, and a lot of women are spending up to one third of their life in the postmenopausal period. So, this is a really important concept for us to learn and understand as up and coming midwives. Also, there are no lab tests associated with the diagnosis of menopause. We tend to diagnose it based off of clinical symptoms, the age of the patient, and ruling out of other conditions. The physiology of menopause. Most women are born with about 1 million ovarian follicles. Throughout their life, those number of follicles begin to decrease through the ovulation cycle, and the rest through atresia, which is a hormonally controlled apoptotic process. As this process continues over the lifespan, it gets to the point where these follicles are under 1,000, and that usually occurs at menopause. This causes a decrease in the feedback um, in the hypothalamic pituitary ovarian axis, which causes, which is due to the number of follicles getting so low, where are an inadequate amount to respond to the follicle stimulating hormone. Due to this lack of response, that means that eggs are no longer released during menstruation. This is also referred to as anovulation. Physiology continued. The typical negative feedback loop caused by elevated estrogen and progesterone on the hypothalamic production of gonadotropin releasing hormone is diminished. LH and FSH then go abandoned and their levels remain high after menopause occurs. Estrogen can be found, in time, ovarian follicle production stops. Progesterone and estrogen levels remain high. LH and FSH levels remain high, and monthly menstruation stops. Women tend to have a variation of symptoms due to estrogen being produced through the conversion of testosterone. But so that means most women or all women will experience a cessation of menstruation, but the variation of symptoms of menopause may vary. Hypoestrogenic changes. Although we typically think of estrogen as it relates to the reproductive system, a variety of body tissues contain estrogen receptors and are affected by the reduction of estrogen occurring post-menopause and during the menopausal transition. Some tissues which do not seem to have estrogenic receptors also change in response to a drop in estrogen. Other symptoms, such as thyroid, appear to be more susceptible to pathogenic disturbances in perimenopause and postmenopause, but it is unclear if this is related to estrogen or other hormonal changes such as alterations in the hypothalamic pituitary axis or FSH, LH, and other hormone levels. Cardiovascular changes. The risk of adverse cardiovascular events include stroke and MI as age increases. However, women appear to experience an increased risk after menopause, which is not sufficiently explained by aging alone. The hormonal alterations of menopause have multiple effects on the heart and vascular system. Estrogen stimulates the production of nitric oxide and decreases synthesis of endothelin 1. Both of these can lead to an increase in blood pressure. An increase in lipid levels and inflammation markers can also contribute to increased calcium and plaque deposits within vessels. A greater amount of fat deposits in the tissue surrounding the pericardium also is a risk factor for cardiovascular events. Early and premature menopause can further increase insulin and metabolic changes. Fat tissues are sensitive to sex hormones, including estrogen. Fat deposit locations are influenced by estrogen, which typically causes more fat to be stored in breasts, hips, and thighs. As estrogen levels drop during menopause, more fat is stored within the waist. Sensitivity to insulin is also affected. As shown in the last slide, there is also increased risk for hypertension and elevated lipid levels. Together, these form metabolic syndrome. While most women do not experience metabolic syndrome as a part of menopause, some studies have found rates in postmenopausal women over 30% which was a significant increase from premenopause. Bone and brain changes. Bone cells respond to lower levels of estrogen by changing the proportion of cells which build or destroy bone tissues. After menopause, fewer cells become osteoblasts, building bone tissue, than before, and more of them become osteoclasts. This decreases bone density and can lead to osteoporosis. Decreased estrogen affects neurotransmitters and cause thermoregulatory dysfunction. This narrows the temperature range which the body considers normal, triggering vasodilation with flushing to perceived overheating. This may be followed by shivering as the body overreacts to the drop in temperature, um, and it causes, um, which is caused and tries to warm the body back up. Thyroid function is affected in some women as well as mood. This is not very well understood, but it's plausible that since the hypothalamic pituitary axis is altered in menopause and estrogen is known to have some effects on neurotransmitter, decreased levels could cause disruption of previous function in thyroid and brain. Genital urinary changes. Urinary tissues are strongly affected by estrogen levels. They also lose some of their sex hormone receptors during menopause and are less able to respond to what estrogen remains. This decrease in tissue sensitivity leads to many of the symptoms seen in menopause and in postmenopausal women. These are major issues for many women, and we'll talk about them in greater detail. Hypoestrogenism. Hypoestrogenism um, causes significant changes. As ovarian follicles decrease in number throughout the woman's lifespan, the loss of these germ cells contributes to the increased decline of estrogen. The inconsistent development of follicles creates marked variability of their secretion of estrogen and inhibin B, a marker of granulosa cell population. There are suggestions through studies that the body's sensitivity to the estrogen positive feedback loop declines and is eventually lost through aging. Of the three types of endogenous estrogen, estrone is the dominant form in menopause. This is also the less effective of the estrogen. This change is another contributor to hypoestrogenism. Hypoestrogenic symptoms. Vaginal epithelium thins, smooth muscle atrophies, vaginal blood flow decreases, tissue elasticity declines, and glycogen decline in vaginal cells, increasing the vaginal pH along with fewer lactobacilli in the vaginal microbiome. The pelvic floor will begin to function less effectively with muscular atrophy, contributing to incontinence. Other symptoms that we may see include vaginal dryness and weight gain. So overall, we can see the symptoms on the left or the right rather of the slide, which include vaginal dryness, vaginal prolapse, postcoital bleeding, decreased arousal or desire, vaginal microbiome, thus increase in pH, vaginal pelvic pain, decreased bladder capacity, lower elasticity slash blood flow, dysuria, incontinence, and UTIs can all be experienced by postmenopausal women. Genital urinary syndrome of menopause, or GSM. GSM is a syndrome of symptoms that include atrophy to the genital urinary areas due to sex hormone loss, particularly estrogen, during menopause. This condition is progressive, chronic, and lifelong, having an adverse effect on quality of life. This does not include the vasomotor symptoms. Inhibin B from the ovaries declines in early ovarian aging, driving up FSH levels as its efforts to recruit follicles intensifies with the message that inhibin B is low. Estradiol's nadir is not usually reached until 1 to 2 years after the final menstrual period. From there, they stay relatively low. Hypoestrogenic management. It is important to assess for any menopausal symptoms upon visits through a thorough medical history and a physical pelvic exam. physical and pelvic exam. Laboratory testing can be involved along with cultures and biopsies if indicated, and initial therapies fail. Differential diagnosis should be ruled out. Two simple questionnaires, the vulvovaginal symptoms questionnaire and the day-to-day impact of vaginal aging questionnaire, have been helpful tools for GSM diagnosis and quality of daily life impacts. Biophysical and psychosocial effects of hypoestrogen may require multidisciplinary support. Obesity, inadequate living habits, and comorbidities can contribute to the quality of life and affect a person's function. Entering and beyond menopause, behavioral therapy may be an overlooked approach to reducing morbidity. A multidisciplinary approach to menopause can provide holistic care for the women. For the women, yes. Lifestyle changes increased lifestyle changes, increased physical activity, balanced diet have all shown to improve vasomotor symptoms, depressed mood, and arthralgia, myalgia, um, and osteoporosis is another result of aging and hypoestrogenism. Treatments. So the goal for treatment is to bring relief from these symptoms. Initial treatments include lubricants and moisturizers that are non-hormonal. The gold standard with best results are the use of hormonal therapies of local estrogen applications. Some newer treatments, which are still being reviewed, are laser treatments and selective estrogen receptor modulators. Non-hormonal therapies include vaginal lubricants, moisturizers, vulvar lidocaine, compresses, laser, microablation, non-ablative laser, serum, oral vitamin D, vaginal vitamin D, and many more. Lifestyle modifications can also help improve symptoms. These include smoking cessation, exercise, high protein and fiber diet, and lowering sugar intake. Systemic estrogen has been found to be less effective than vaginal estrogen. Intravaginal tablets, rings, and creams with low estradiol concentration have shown best outcomes. So there's many options for these hypoestrogenism symptoms, and it's great to know all these options when it comes to diagnosing and also treating our. And here are our reference. We hope you guys enjoyed and happy studying.